Good, thank you. I remember I was in this event, I think it was 2019. Was that the last time this was organized? I was then at the audience, but happy to be on stage today. And I know the name of the event is Health Design, but I actually want to start with the other side of the story. Because how many of you knew that cardiovascular disease is actually the reason behind 30% of all deaths globally and in Finland? How many knew? Hands up. Quite many, because I think the one that comes second, cancer, is actually the one that people usually assume, but the cardiovascular disease is the biggest reason. And at the moment, how does this work? Oh, right. There are over 300,000 people living with ASCVD in Finland. That's more than population of Espoo. And because the volume is so big, also the costs for society are big too. So annually, on average, the cost that these cardiovascular disease cost per citizen is actually 640 euros annually. So each of us, even though we wouldn't have the cardiovascular disease, that's the volume. The sad news is that many of these patients actually find out that they have ASCVD only after they have had myocardial infarction. And annually in Finland, 11,000 people survive the infarction, which is basically the same thing as a heart attack. The good news is that it is actually impossible to prevent further events, because these patients who have had their first heart attack have a very high risk of getting a new one. But if we're able to control some risk factors, for example, LDL cholesterol, we can lower this risk and with that the costs. The sad news is that this risk factor controlling management is called secondary prevention, is not happening optimally in Finland at the moment. So we know that at the moment, 1 in 5 patients actually has another heart attack within a year. And even more patients when we look at the 5-year time frame. The good news is that a couple of years ago, we got a national cardiovascular disease register in Finland, a quality register, where we can see how this secondary prevention is happening in Finland at the moment. From the data, we see that actually 40% of these patients have not had their LDL cholesterol measured within 18 to 30 months after the heart procedure. So we're not doing well on secondary prevention. And as said, the cost of this is big. So I want to share with you today how we at Novartis Finland have approached this problem together with our partners. But before I do that, I want to quickly introduce myself. I'm Pinja Krug, and even though I dropped some medical knowledge here, I'm not a medical expert at all. My background is in service design. And in Novartis Finland, I work as a healthcare partnership director, and I lead a team of service designers and strategic designers. And so we have a quite unique team. We partner together with Wellbeing Services counties and other partners. And one of the most common questions I get is, why does a pharmaceutical company like Novartis have service designers? Because we're a huge global company. We have over 70,000 employees globally, 100 being in Finland. And here you can see our core therapeutic areas. We have a very solid scientific background. We invest a lot to science. So why do we have service designers? So we actually want to be our motto is that we're part of healthcare, because if the patient isn't at the right place at the right time, how can they get the optimal treatment? And this is the reason behind why we have invested in service design and why do we do partnerships. And I think cardiovascular disease is actually a great example of where we have a clear common goal between all the stakeholders. Because obviously it's terrible for the patients and their close ones if they have to face this reality of getting a heart attack or then have recurring events. It's also very heavy on the resources in healthcare for the healthcare professionals if the patient keeps coming back because of the same reason all the time. And as we know, the costs for the society and for the well-being services counties are huge. But it's also the common goal is clear for us in Novartis, because if the patients disappear after having the infarction, how can they be treated? So that's the goal of the partnerships in Finland for us. But coming back to how we approach this problem, is that a couple of years ago, we created this ASCVD program called Sydänohjelma Polku. And our aim is to improve the secondary prevention in Finland. And there are a couple of steps we do in Polku, and we have now partnered with 4 different well-being services counties in Finland. And we always start by understanding the disease burden in the area, and we can then model the impact potential of prevention. But I'm not an expert on this, so I have a short video of our medical lead and our external partners. So let's hope this works. It's a 2-minute video.
Novartiksen, Siun Soten ja Esiorin yhteistyössä tekemä tutkimus tarkasteli sepelvaltimotautitapahtuman saaneiden potilaiden uusintatautitapahtumariskiä ja hoitoon liittyviä sosiaali- ja terveydenhuollon kustannuksia 5 vuoden seurannassa. Tämä uusi tutkimus antaa tietoa sepelvaltimotautitapahtuman jälkeisen sekundaariprevention nykytilasta ja hoitoon liittyvistä kustannuksista Siun Soten alueella.
Tässä tutkimuksessa pystyttiin osoittamaan se, miten sydänpotilaiden kokonaisriski on yhteydessä pitkän aikavälin sote-kustannuksiin. Tutkimuksessa potilaat jaettiin 5 eri riskiluokkaan pohjautuen heidän sydäntautitapahtuman uusintariskiinsä. Tutkimustulos on myös se, että me käytimme tässä tutkimuksessa Smart Reach riskilaskuria luokittelemaan näitä potilaita heidän tämän uusintariskinsä perusteella. Ja tämän käyttö vaikuttaa hyvin lupaavalta. Ehkä yhtenä keskeisenä havaintona myös se, että kun tarkasteltiin näissä riskiluokissa potilaiden LDL-arvoja, niin edes korkeimmissa riskiluokissa ei saavutettu riittäviä hoitotavoitetasoja.
Tutkimuksen tulosten perusteella voi olla mahdollista luoda työkalu, joka helpottaa suuren riskin potilaiden tunnistamista ja samalla luo motivaatiota potilaan riskitekijöiden hoitoon sekä potilaan että henkilökunnan kannalta. Aiomme hyödyntää näitä tuloksia esimerkiksi digitaalisissa hoitopoluissa. Aloitimme vuosi sitten sepelvaltimotaudin digitaalisen hoitopolun vakaoireista tautia sairastaville potilaille ja nyt helmikuun alusta olemme aloittaneet myös sydäninfarktiin sairastaneille potilaille vastaavan digitaalisen hoitopolun. Sepelvaltimotautikohtauksen jälkeen riskiluokittelu voi auttaa potilasta ja hoitavaa lääkäriä yksilöllisen hoitosuunnitelman laatimisessa. Tämä uusi tutkimus osoittaa, että keinoja löytyy hoidon vaikuttavuuden lisäämiseen, koska uusien sydäntapahtumien estäminen säästäisi hyvin merkittäviä summia kokonaiskustannuksissa.
Riskiluokittelulla päästään tällaista perinteisestä one fits for all -ajattelusta, jossa lähtökohtaisesti kaikkia potilaita hoidetaan samalla tavalla, kohti stratified medicine -ajattelua, jossa potilaan kokonaisriski on se keskeinen tekijä sen hoidon toteutuksessa. Tätä kautta me päästään rajallisten resurssien tehokkaampaan käyttöön.
Laadukasta terveystietoa tarvitaan terveydenhuollossa päätöksenteon tueksi. Tämä tehty tutkimus on vain yksi esimerkki siitä, minkälaista yhteistyötä me voidaan tehdä eri hyvinvointialueilla, jotta potilaiden hoitoa voidaan kehittää entistä vaikuttavammaksi.
Yes, so we did this study in Siun Sote, but now we have a modeling tool which we can utilize in all other well-being regions in Finland to really understand, as said, the current situation, but also to simulate how, for example, treating certain risk factors, what's the outcome for the risk for the patient to have another heart attack, but also what's the impact on social and healthcare costs in a 5-year time frame. So we start with the data to really define what the problem looks when looking at the data. But then we move to what, as a service designer, is kind of the core for me. So we are in the healthcare service county. We interview patients, we interview specialists, physicians, nurses, both in specialized healthcare and primary healthcare. We really try to understand what are the current ways of working. Where are these patients? Because they don't disappear. They might be in other clinics. What are the ways of working there? And then we identify the key stakeholders that we collect together to really co-create the solutions. And here we do it always tailor-made based on the area. So we don't have any ready-made solutions we bring. We look at the regional needs and then also their existing systems. What would work for them and be easiest for them to use. So as said, our aim is to improve secondary prevention in the area. And we're doing this work in multiple areas, but we also have some great results already that I want to share with you. Last year, Heart Hospital launched their digital follow-up for ASCVD patients in September. And we partnered with Sydänsairaala to really understand the needs from patient perspective and healthcare professional perspective on what would be the optimal digital follow-up for these patients. And this Oma Sydän app, My Heart app, is also integrated based on those findings to their ERP system so that the nurses and physicians don't have to do a lot of manual work. Everything is as easy for them as possible. So this was launched in September, and now patients get, after they have gotten home from after their heart attack, they get automatic reminders of their check-ins and follow-up visits. They get support and guidance so they can treat themselves optimally at home. And they can also contact Sydänsairaala Heart Hospital through this app. And the results are really great, because we can already see that over 75% of patients hit their LDL cholesterol target during the 12-month follow-up. And we can also see from the National Coronary Disease Register that on average in Finland, it's usually just over 20%. So the difference is big. Secondary prevention is actually happening in heart hospital areas. And maybe some of you remember this because this won the Effectiveness Award last year in Vaikuttavuusseura event. But I want to end with not just the data piece, but a quote from a patient that took part of interviews and co-creation sessions in this. Sorry, it was trying to put some automatic update, Otto, just for you to know. But yeah, this is a quote from a patient that we interviewed during the creation of the app. And I think this quote shows well that even though data is very useful, we needed to set goals to really understand the current state and to track our progress. And officially, secondary prevention is about controlling those risks. But I think that the more interesting part is actually the people perspective. Because what we found out through these interviews is that when these patients got home after the heart attack, most of them were really scared. They knew in theory, that they should be active, they should take care of themselves. But most of them said that they're even afraid to go for a walk or a jog, because what if they get a new heart attack when they're out there alone? So they ended up, they wanted to live their life, but they really didn't know how. And that's why, for example, the support that was created to the app is really trying to motivate these people to stay active. And I think that's what a good secondary prevention looks like. It's not just about the numbers, it's also how can we design seamless services that really support people in what they want to do, live a full, happy life. That's important, not just the numbers. Thank you.